All right, good evening and welcome to today's discussion. The first question is there on the screen and standard deviation question. In a normal distribution curve, the mean plus or minus 2 standard deviation equals what percentage of the area under the curve? Option A 68%, option B 95, option C 99, option D 99.9. All right. You guys can post in the group for others to join. Okay. Yeah, B is the answer. That's this 95% is regarded as the confidence interval. Okay, that's basically the values that within which most of the population, that's more than 95% of the population, will fall in. Okay, and that's what is used for reference ranges. And which of the following is the most sensitive to erythropoietin? We have reticulocytes, CFU, normoblast, erythroblast. Of course, it's colony forming units for erythroid colony forming units will be most sensitive to erythropoietin, followed by reticulocytes in that option. Or even normoblast before. Reticulocyte will come before the proper red blood cells, so it's even lower down. Normoblast, erythroblast, then before reticulocyte, before the red blood cells. So the next question is asking about the weight of market woman. Okay, the weight of market women is normally distributed if the mean is 40 kg with an SD, that's standard deviation of 5 kilograms. What proportion of the women will weigh more than 50 kg? This one will need some mathematics. So first of all, like you calculate the Z score, and the Z score is like 50 minus 40 divided by 5. That's which is one standard deviation is 5. So it means that um, 50 minus 40 will give you the number of standard deviations. Okay, so then when you divide it by 5, you get 2. That means it's 2 standard deviations away from the normal. Okay, and when you plot that on a graph, or when you use this calculator, the z-score of 2 corresponds to probability of 97.72% of the women who weigh less than 50 kg. Okay, so if you want to find the proportion of those who weigh more than 50 kg, you subtract this value from 1. So 1 minus 0.9772 will give you 0.0228. Hope you understood the calculation they did there. Just 50 minus 40 divided by 5, which is equal to 10 over 5, which is equal to 2. So 2, that's 2z score. Okay. I'm sure if they are giving you this type of question, they'll probably give you a chart to look up z score or something. So if you have 2z score on the graph, what you get is 97.72%. Now, this percentage is the number of people who are below 50, like who weigh less than 50 kg. Okay, so if you want to get for those who weigh more than 50 kg, you just basically do 100 minus this, or you do 1 minus 0. 97.72% is something at 0.9772. So that will give you that option 1 in your calculator. So that's basically how it's derived. You need a chart of the Z score. This is two standard deviation, which is you check it in the Z score chart. Okay, that's how you get the 97%. Okay, so Go to the next question. Mechanism of DKA include all except decreased gluconeogenesis in the, let me copy the question, in the kidney, in the liver, decreased insulin secretion. These are the options. So in DKA, despite the body being in the midst of plenty of sugar, glucose, drowning in sugar, it's not able to use it because of insulin deficiency. So the body now thinks that it's glucose that is lacking and starts trying to increase glucose production from non-glucose substrates. And of course, even in DKA, ketones and which are also like substrates for gluconeogenesis and lactates, lactic acid are also increased. So there's even a leeway for it to be utilized during gluconeogenesis. So which vaccine produces immunity by T cell mediated immunity? We have BCG, diphtheria, yellow fever, OPV. Okay, on the control of breathing, so of course BCG is correct. On the control of breathing, which is correct, low partial pressure of oxygen stimulates the medullary center. High carbon dioxide inhibits peripheral and central receptors. Low pH stimulates medullary center. Low partial pressure of oxygen stimulates both peripheral and central receptors. So the medullary chemoreceptors, they are very sensitive to pH and carbon dioxide levels. Okay, so um, it detects acidity. That's what it does. Okay, and of course low oxygen and high carbon dioxide levels. But the primary sensitivity is pH in the medullary center. All right. It has only two options, but just use it like that first. Um, the man develops abdominal distension and flatulence whenever he takes carbohydrates, which is the likely cause. Deficiency of disaccharidases, tropical sprue. Let me give you some more options. So, though the answer is already obvious from the other one. So, it's deficiency of disaccharidases because it particularly um, happens when they take carbohydrates. Okay, A woman brought her 18-month-old twins to the hospital complaining of abnormal behavior and inability to color after a change of cereal. Inability to color. What's that? Okay, inability to color after a change of cereal that contained aspartame. What's the diagnosis? 18-month-old twins. That presence of twins means that it has to be a genetic stuff. Okay, so abnormal behavior and inability to color. I don't know what that means in particular, but maybe the giveaway is like a cereal that contains aspartame. So you have to look for something that reacts to aspartame, or something that aspartame is one of the amino acids. So you have to look for like an enzyme deficiency that has to do with that. So aspartame is an artificial sweetener that contains phenylalanine. Okay, phenylalanine is one of the amino acids. Okay, this aspartame sweetener. Okay, so individuals with phenylketonuria have a deficiency in the enzyme called phenylalanine hydroxylase, which is needed to break down phenylalanine. Okay, so if they consume aspartame, they will now have to build up because they don't like have that enzymes. So basically leading to neurologic problems and toxic problems. So urban yellow fever is transmitted by which vector? We have here urban Aedes aegypti, Hemagogus, female Anopheles, and none of the above. Aedes aegypti. the Frank Sterling law, which is considered afterload, venous pressure, arterial pressure, aortic impedance, and diastolic volume. There's preload and afterload, right? Afterload is what happens after the heart. Preload is what happens before the heart. So you have to think of it that way. You can easily figure it out. So it's arterial pressure. After the heart, what happens? Blood leaves through the aorta, majorly from the left ventricle, okay, towards the body. So the afterload is that pressure in the aorta. Okay, that's where means if there is systemic hypertension, okay, you are going to have a high afterload. So it means there's more pressure with which against which the heart must pump in order for blood to get to the body. That's the afterload. But preload is like the venous return, all the amount of blood that returns through the vena cava, that's superior vena cava and inferior vena cava. So all those ones will contribute to preload. Okay, so what's that popular formula? Cardiac output is what? Cardiac output is what? Is it stroke volume?
What? And diastolic volume and systolic volume times how many?
Which one is stroke volume times heart rate? Yeah, I understand what you're saying anyway, but like it's a different way of thinking
That's
about it
true.
too.
Yes, yes.
It's still a different way of thinking about it. So it's still this same cardiac output is still that one you're talking about, like what do you call it? And diastolic volume. And so cardiac output is stroke volume times heart rate. And what's the other one again? Heart rate is determined by sympathetic discharge. Uh, what are all those medications that lead to increase heart rate? All those medications and things like that. They are the determinants of heart rate. Then stroke volume itself is determined by the end diastolic volume, right? Mhm. There's still another place where cardiac output is used. Is it blood pressure? I can't remember the formula. Anyway, so what's the cardiac output for most adult patients? If it's stroke volume times heart rate, you can actually derive it. That's you expect about 70 um, mils per minute of stroke volume. That should be the minimum. Then heart rate's about 70. So 70 times 70, that's 4,009. So on the average, 5 liter per minute is a cardiac output. These things are not rocket sciences. You don't have to cry anything. A lady got a gift of earrings and developed rashes weeks later um, with bule. What is the next line of action? Stop wearing it. Topical calcineurin inhibitors, oral steroids, patch tests. When you see someone with an allergy, the first thing should be to try to verify what she's particularly allergic to. And okay, so we do a patch test first because they're asking you for the next line of action. They are not asking you for the the best management or whatever. And when you before you make a diagnosis, you do investigations. So that's your next line of action. So option D is the answer. From which gem gem layer does the dermis develop? Ectoderm, mesoderm, endoderm, and periderm. Do you know the meaning of endo? Endo means inside. So which gem layer is the epidermis from? Because the epidermis is the outermost layer of the skin. That's the cells that line the epithelial cells that line the skin. That's what you actually see when you're looking at the skin. Then apart from under it, you have the melanin producing cells, the melanocytes. Okay, that's in the lowermost layer of the epidermis. And so because it is epidermis is outer, so it has to be ectoderm, which is the outermost layer. Then the dermis itself and subcutaneous tissues and muscles, they are produced from mesoderm, the middle layer in embryological origin, germ layer. So it's the middle layer. Then endo is where all those intestines and things like that will come from. Okay, because inside they are inner. So that's why things like that like the hair and the hair follicles and the glands. Okay, even though some of them are found in the dermis, okay, they actually have ectoderm origin. They were only dragged down in the process of embryological this thing. They came from the ectoderm, but they were dragged into the dermis as the development is going on, just to give them a deeper root. That's why your hair, this thing, is difficult to pull, and when you pull it, you feel pain because it's down. It's in the dermis. Okay, so but meanwhile, its embryological origin is still from the ectoderm. Ages we are giving, okay. Ages we are giving as 12, 13, 14, 15, 16, and 45. Which of the following measures of central tendency will you use? Option A, mean, standard deviation, median, and mode. If you look at this range of data, you'll see that it's a data that has a skew. Why the initial data were linear and symmetric, the last one, which is 45, is widely skewed. Okay, so you have to look for the best measure that will capture central tendency in data set that is skewed. They can also ask you this way: what's the best to use? What's the best measure of central tendency in skewed data? They may not give you the values; they'll just say skewed data. So if the data is skewed, is the median that you will use. Because I'm sure if you calculate the mean will still be skewed. But if you use the median, it will bring you closer to the middle. The mode, there's no mode here because everything is 1 1. So, what is the mode of inheritance of sickle cell disease? Autosomal dominant. This one is a big question. Sex linked recessive, autosomal recessive. This is autosomal recessive. Which of the following causes of hyperparathyroidism does not respond to increasing calcium levels? Parathyroid adenoma, amyloidosis, hypercalcemia of malignancy. So it's parathyroid adenomas that will cause this kind of situation where primary hyperparathyroidism, where the adenoma is just producing excess parathyroid hormone. So they no longer respond to, of course, that makes sense because malignancy means it's going to be autonomous. So they are not responding to serum calcium levels. Normally, parathyroid hormone is supposed to respond to normal serum calcium levels. So the next question: a man with polyuria and polydipsia has a serum calcium of 3.2. What's the classification of his hypercalcemia? They gave you a normal calcium level 2.1 to 2.6. So is it moderate? Is it mild? Is it life threatening? Is it severe? So since they already gave you the value, you can extrapolate. Usually they vary by 0.2, 0.2 ish. Anyway, we can go 2.1 to 2.6, 2.7 to 2. Let's go by 2 or 3. So 2.7 to 2.8 or 2.9, then 2.9 to 3.0. Then anything above 3.0 or above 3.1 or 3.2, I think we'll regard it as life threatening. So anyway, depends on like the source, but it's between severe anyway and life threatening. Okay, we need to check a standard medical textbook. So a woman with decreased sensation when she touches cold objects, mottling and hardening of her skin, which antibody will likely be involved? Okay, we have antitopoisomerase, anti-DS DNA, anti-nuclear antibody, that's ANA, ANCA, anticentromere. If you get the diagnosis, you can get the antibody that is involved very easily. So whenever you see, you have to know the characteristics of all these what do you call them? Autoimmune diseases, right? So SLE, scleroderma, okay, things like that. So this is a classic presentation of scleroderma. That hardening of the skin is particularly distinct. That cold mottling, that one is could be, you can regard it as like if it's on the fingers, you can regard it as Raynaud phenomenon, but like the hardening of the skin, that's scleroderma or systemic sclerosis. And so usually anti-SCL70 is the classic this thing, and another name for that is anti-topoisomerase 1. So they're found in patients with diffuse cutaneous systemic sclerosis. So many of those other autoantibodies will also be positive. ANA will be positive because ANA is non-specific and it's positive in a lot of um, autoimmune diseases, but it's highly positive in SLE. But this one is specific for scleroderma. So a woman on antiretrovirals comes for follow-up. A viral load is around, it's found to be 6,000 copies per mil, but she has no symptoms. What's the next line of action? Change to second line therapy, carry out sensitivity tests, adherence counseling, repeat in 3 months. Yeah, in this situation, is either she's not taking the medication well or the medication itself is not working. So it suggests treatment failure, and poor adherence is the most common cause of virologic treatment failure. So you start from there and then you progress to sensitivity testing as the next line after that one. Now that USA has cut off US aid, hearts is no longer, I don't know what's obtainable now, but it may have its effects. Anyway, what's the best marker for evaluating primary hypothyroidism? Free thyroxine, that's T for TSH, thyroid antibodies. Like if you want to do thyroid function test and let's say um, you don't have the time or the resources, or the patient does not have the resources to do all of them, if there's one single test that you do that will tell you something, it should be the TSH, okay? Because T3 and T4 can be high, they can be low, they can be normal, okay? But TSH, the direction of TSH is very, very important in making a diagnosis. HIV positive woman on hearts presents with progressive weakness and hyperpigmentation. She has no response to synactine tests within 30 minutes and 60 minutes. Uh, what's the best next line of action? Steroids therapy, ACTH therapy, aldosterone therapy, cortisol therapy. It's possible that the virus have shut down her adrenal gland. So the symptoms you're seeing there are like pictures of Addison's primary hypoaldosteronism. So, sorry, primary adrenal insufficiency. So, cortisol, they will have to be on cortisol for life. Steroid is a generic term. If you are to choose between steroid and cortisol, you should choose cortisol because cortisol is more specific, and that's what you particularly want to use. Which test is important in evaluating a patient with Cushing's syndrome? Low dose dexamethasone suppression test, 24 hours urinary cortisol, 8 a.m. serum ACTH, 9 a.m. serum cortisol.